The idea is that we'd love to hear from Neels, Dr. Groenewald, about this coming out of Seattle Pediatric Hospital. Neels, can you hear me okay?
Yes, I can hear you, Stan. Thank you.
Wonderful. Great, great. Well, first of all, welcome to the symposium and thank you for joining us. And again, we've got people watching from all over the world and very interested in your research and your work using intelligent medication solutions around and with opioids. Obviously a hot topic here in the US healthcare system and globally as well. But maybe you can just give a 1-minute overview on yourself and what you do at Children's.
Yeah, thank you. Yeah, so I'm a pediatric anesthesiologist and a pain physician here at Seattle Children's Hospital and the University of Washington. And I'm also a public health researcher focused on the opioid use and opioid epidemic as it affects adolescents. And, I think we're all familiar with the opioid epidemic in the United States that affects adults. And we know that there's been overprescribing of opioids to adults. The pharmaceutical companies have played a role in that, but also physicians. But that's really focused on adults. In adolescents, though, no one has ever really overprescribed opioids to them. They didn't go to these pill mill clinics or the chronic pain clinics. But what happens with adolescents is they get introduced to an opioid, after surgery or after trauma or at their pediatrician's office. They get prescribed a certain amount of opioids, and then they usually don't use them all. And then they have a large amount left over at home. And then in future, they then misuse those leftover opioids. And that is how they sort of enter into this opioid pathway that goes on to opioid misuse and, eventually overdose and heroin use. Now, the opioid epidemic is dynamic. There's many pathways to this, but this definitely is one pathway. And but our research then is really focused on, but no one really knows how that pathway develops. And so our research is focused on understanding sort of what happens after an adolescent gets their first opioid prescription. How do they use it? What are the factors driving this use? Is there different patterns in use? And this has really never been studied. And so we use a electronic medication adherence device from a company called Information Mediary Corporation. And we have them after surgery, so after knee surgery in adolescents, we have them place their opioids in this container. And then we can really closely track their opioids and know exactly when they're taking them sort of over the first 2 weeks after surgery. And then we follow up with them again at 2 months, 6 months, and 12 months and ask them about further opioid use or opioid misuse. And at the same time, while they're using the opioids, we're also asking them every 4 hours sort of what their pain is doing, how their stress levels, about their mood, physical activity, and then also we ask them about history of substance abuse and related factors.
Yeah, and I think the amazing thing is that you've been using these intelligent package solutions now from Information Mediary for about 18 months now. How many months have you been using them in your study?
Yeah, we started using them in November in 2019 up till now, and this study is still ongoing.
And how is this type of digital intervention in your study, where you can now see when patients and subjects are interacting with the medication? How has it changed some of your perspective around your research and understanding your subjects better around dosing frequency and timeliness?
Yeah, so the medical model right now is to give everyone the same amount of opioids because you don't know who's going to need more, who's going to need less. But I think, so one thing I've learned from this is that there's huge variability between how patients use opioids, and that we can identify sort of before surgery who's going to need more and who's going to need less. And we've also been able to actually reduce the amount of opioids that these children receive, sort of from 18 tablets down to 12, and that because that's about how many most of them use. So that reduces the amount of leftover medications at home. And then we've also found that they don't really use the opioids as we prescribe them. So they get prescribed to be used the first 3 or 4 days after surgery every 4 hours. But almost none of the patients use them like that. They use them for several weeks afterwards. So there are discrepancies about how we think they're using them versus how they're using them in real life.
So it sounds like now that you're using this intelligent medication platform, you have a much better understanding of the reality of patient relationship with dosing, timing, and frequency. Is that correct?
That's correct. Now, let me just highlight that I'm still in the research phase of this. It hasn't been widely disseminated. But yes, they're using it differently. And my hope is that in the future, we can use some of this information in real time to advise children on how to use their pain medications, when to stop using them, when to get rid of them. But that is very much in the future right now.
No, it's absolutely fantastic, and it's really good to know. And so given that you've done research for many years, and now you're seeing how the research is so different when you really do begin to understand how patients and when patients are interacting with their medication, and are they doing it at the right time of day, do you think that this should be a standard for all studies going forward, that investigators should really make sure that they understand when medication is being dispensed to make sure that the frequency and timing is correct?
Yes. So again, I can only comment really on opioids specifically, but I think that we have this vast number of childhood conditions that's being treated with opioids, and all of them need different amounts of opioids. They all have, and it's not just the conditions, but also the patients have their own, personalized risk factors or protective factors. And so we can't do sort of this one size fits all for patients. We need to individualize these medications to reduce the risk. And so the only way that I know how to do that right now is with this sort of technology. Because, if patients, the other way to track medications is have patients do retrospective recall or fill in diaries, but we've actually have that data and the technology data and found that the technology data is just much more accurate. People just don't, they're not able to honestly report how much opioids they use.
No, that's really fantastic. And there's really some interesting relationships here, because I've led hundreds of digital health studies over the last 30 years, and there's a point at where you go from best practice to where you go to ethical practice, to you go to regulatory compliance practice, to where you go legal practice. And so you have these 4 different layers of practice. Do you think that the need to have this type of digital intervention, this intelligent medication solution, should these intelligent medication solutions be, at what level do they fall? Should it be just best practice, ethical, regulatory, or legal? Where do you think the bar is drawn to ensure that we're protecting not only the patients and the studies, but as investigators, but we're also protecting the tens of thousands or potentially tens of millions of patients that will be utilizing these medications after the studies are over? Where's the bar put down for investigators globally going forward?
Yeah. So I think this is very much focused on clinicians, but I think given the opioid epidemic, and given that we're precipitating much of it by prescribing opioids to children and adolescents, and let me also say, opioids are absolutely indicated for pain management in adolescents. Untreated pain has its own consequences. So we are not going away from opioids at this point in time. But I think we have an ethical responsibility. It at some point will become standard of care. At some point, I'm sure it'll become regulatory. It is hard to implement, though. How do you implement this in a clinical practice? But I think over the next few years going forward, especially in the case of opioids, that this will become, I think this has a reasonable chance of becoming standard of care. We really need to match opioids to how people are using them. And we need to understand that is a part of the therapy or the management we do for people, and that our care don't end when they leave the office, that we have to keep an eye on them when they're at home, when they have these medications. So if we can figure out a way how to better, how to get the clinicians to better incorporate that into practice. These devices aren't expensive as far as the overall care that patients are receiving, especially given their risks. yeah, I think this will go through those 4 steps you mentioned. I think it should.
That's fantastic, and I think that's a really interesting thing. We're seeing digital now affecting so many different aspects of the healthcare system, clinical trials being one of the major aspects. And again, we had Joe Mather from Pfizer, who heads up the advanced science group there, talking about decentralized trials. Well, and we know a lot of pharmaceutical companies now are, and academic medical centers and investigators like yourself are really trying to leverage as much passive data collection as possible in these studies. So, we've got about 4 minutes left. What do you think is the future of these sorts of passive data collection tools and opioid use in the United States?
I do. This is not not necessarily my area of expertise. I think it's just, I think the future just is incorporating this into, taking this from researchers like myself and incorporating this into clinical practice. And I think there is, there's ample opportunity to do that. I don't necessarily think, I think that those things can be done automatically. I don't think it needs extra manpower necessarily, but just taking this data that we're collecting on patients and using it to make sort of clinical decisions that's in their best interest, I think is feasible to do. I think that's the future. I think we can make a difference in patients' outcomes by acting in real time on sort of this passive data that we're collecting.
Yeah, that's fantastic and really well done there. And what can the regulatory community, what can the life science community do to help facilitate this future where we see more of these technologies in place, not just in clinical trials, where it sounds like you're almost saying it really should be mandatory, but also in everyday patient usage at home?
Well, we need more data. And so as far as I know, I'm the only person doing this specific type of study and in one specific patient population. But really to get this sort of more standard of care, we need more research studies so people can show that this is working. But I think that is the main barrier right now. It's just the data to show that whether this will work or not, whether this will work or not, but just more data to show that this it is feasible and that this is a good idea. So more research is needed. That's the first thing we need right now.
Outstanding. And as a researcher, I love to hear that. And I can't agree more. I think it's